In this video, we will cover arterial blood gas interpretation. An arterial blood gas analysis or ABG analysis measures the balance of oxygen and carbon dioxide in the blood to see how well lungs are working. It also measures the acid-base balance in the blood. Kidneys and lungs work to keep acid-base balance. When there is an imbalance, that means blood has either too much acid, that is acidosis, or too much base, that is alkalosis. If untreated, the imbalance can be harmful and even life-threatening. This test is done if a person has trouble getting oxygen into the system because of lung disease such as pneumonia or emphysema. And also people on a breathing machine or who have a kidney disease, kidney failure, diabetes, shock, chronic vomiting or other conditions may have problems with the acid-base balance in their body. For them also we do ABG analysis. Here are some of the more common reasons an ABG is ordered are shortness of breath, unusually tired, confused or disoriented, chronic vomiting or nausea, shock, smoke inhalation injury, carbon monoxide poisoning, burns in the airways, drowning accident or for decompression sickness, drug overdose, head or neck injury and have trouble breathing, a condition that can affect breathing such as asthma, chronic obstructive pulmonary disease, myasthenia gravis or Guillain-Barré syndrome. And also a newborn is having trouble breathing. For such people, we do ABG analysis. What are the components of ABG or what we look for? Mainly 4 components are there. They are pH. pH measure acid-base balance of the blood. PaO2. It measures the partial pressure of oxygen in the arterial blood. PaCO2. It measures partial pressure of carbon dioxide in arterial blood. HCO3. It calculates concentration of bicarbonate in arterial blood. Now we will see normal arterial blood gas. Normal pH is 7.35 to 7.45. Normal PaCO2 is 35 to 45 mmHg. Normal PaO2 is 80 to 100 mmHg. Normal HCO3 is 22 to 26 milliequivalent per liter. If the pH is below 7.35, it is acidic. If it is above 7.45, it is alkaline. If the PaCO2 is below 35, it is alkaline. If it is above 45, it is acidic. If HCO3 is below 22, it is acidic. If it is more than 26, it is alkaline. Blood is taken for ABG analysis either from radial or femoral artery. If you are taking blood from radial artery, we should check the blood circulation of ulnar artery by doing the Allen test. Before performing the arterial puncture, however, it is important to assess the blood supply to the hand and fingers, particularly to assess the patency of the ulnar and radial artery. Allen's test does not require special instruments or devices. Through this test, it is possible to verify the integrity of the collateral circle of the hand. Let's see how it works. First, palpate and locate both the radial and ulnar arteries. Ask patient to make fist tightly and elevate hand by flexing from elbow. Alternatively, patient can close and open fist for couples of times to increase blood drain from hand. Next, compress ulnar artery and radial artery simultaneously with the thumb or fingers. Patient is then asked to open and relax his or her hand and should appear whitish and blanched. The examiner then releases pressure from ulnar artery while keeping pressure on radial artery. Then observe how long it takes color of the palm to return normal. If the color returns normal within 5 seconds, it indicates normal collateral blood circulation of the ulnar artery. The same procedure is again performed for the other artery. Typically, hand recoloration takes about 5 to 7 seconds if adequate vascularity is present. If the color of the hand, however, does not return to normal within 7 to 10 seconds, it means that the artery is not completely pervious. After taking blood from any artery, we have to apply pressure. If it is radial artery, apply pressure for 5 minutes. If it is femoral artery, apply pressure for 10 minutes. How to understand whether the patient is having acidemia or alkalemia, whether it is respiratory acidosis, alkalosis, or metabolic acidosis or alkalosis. The first step is to look at the pH and assess for the presence of acidemia or alkalemia. If the pH is below 7.35, it is acidemia. If the pH is above 7.45, it is alkalemia. If the pH is in the normal range, use a pH of 7.40 as a cutoff point. In other words, categorize a pH of 7.37 as acidosis and a pH of 7.42 as alkalemia. That means if the pH is below 7.4, we consider it as acidosis. If it is above 7.40, we consider it as alkalosis. Next step is to evaluate the respiratory and metabolic components of the ABG results, the PaCO₂ and HCO₂ respectively. The partial pressure of carbon dioxide indicates whether the acidosis or alkalemia is primary from a respiratory or metabolic acidosis or alkalosis. Partial pressure of carbon dioxide more than 40 with a pH less than 7.4 indicates a respiratory acidosis. Partial pressure of carbon dioxide less than 40 and a pH more than 7.4 indicates a respiratory alkalosis. Bicarbonate less than 22 with a pH of less than 7.4 indicates a metabolic acidosis. Bicarbonate more than 26 with a pH of more than 7.4 indicates a metabolic alkalosis. Assess for evidence of compensation for the primary acidosis or alkalosis by looking for the value PaCO₂ or HCO₂ that is not consistent with the pH. If the pH is higher or lower than normal, our body tries to bring it back into normal range is called compensation. If the pH is normal and HCO₂ or CO₂ is abnormal, it is compensated. If pH is abnormal with the abnormal HCO₂ and HCO₂, it is uncompensated. If either the PaCO₂ or HCO₂ value is varying to compensate for the primary acid-base disturbance, but the pH is still not within the normal physiological range, it is called partial compensation. Uncompensated respiratory acidosis occurs when there is an increase in the partial pressure of carbon dioxide level without a resultant alteration of the HCO₂ value. Thus, there will be an acidosis due to respiratory failure, inability to remove excess carbon dioxide from the blood and the lungs. Partially compensated respiratory acidosis occurs when there is an increase in the partial pressure of a carbon dioxide level with a resultant alteration, that means increase of the HCO₂ value, but the pH is still not within the normal range. Thus, there will still be acidosis due to respiratory failure. Fully compensated respiratory acidosis occurs when there is an increase in the partial pressure of a carbon dioxide level with the resultant alteration or increase of the HCO₂ value, thereby balancing the pH within the normal range. Thus, there will be compensation for the acidosis due to respiratory failure. With metabolic alkalosis, uncompensated respiratory alkalosis occurs when there is a decrease in the partial pressure of carbon dioxide level without a resultant alteration of the bicarbonate value. Thus, there will be an alkalosis due to respiratory failure. In this case, we can see excess carbon dioxide exhalation from the lungs and reduced carbon dioxide tension in the blood. Partially compensated respiratory alkalosis occurs when there is a decrease in the partial pressure of carbon dioxide level with a resultant alteration of the bicarbonate value, but the pH is still not within the normal range. Thus, there will be an alkalosis due to respiratory failure. There also excess carbon dioxide exhalation from the lungs and reduced carbon dioxide tension in the blood can be seen. Fully compensated respiratory alkalosis occurs when there is a decrease in the partial pressure of carbon dioxide level with the resultant alteration of the bicarbonate value, thereby balancing the pH within the normal range. Thus, there will be compensation for the alkalosis due to respiratory failure. With metabolic acidosis, uncompensated metabolic acidosis occurs when there is a decrease in the bicarbonate level with the resultant alteration or decrease of the partial pressure of carbon dioxide value. Thus, there will be an acidosis due to metabolic failure. It is because of the inability of the kidney to retain adequate bicarbonate. Partial compensated metabolic acidosis occurs when there is a decrease in the bicarbonate level with the resultant alteration or decrease of the partial pressure of a carbon dioxide value, but the pH is still not within the normal range. Thus, there will still be acidosis due to metabolic failure, inability of the kidney to retain adequate bicarbonate. Fully compensated metabolic acidosis occurs when there is a decrease in the bicarbonate level with a resultant alteration or decrease of the partial pressure of carbon dioxide value, thereby balancing the pH within the normal range. Thus, there will be compensation for the acidosis due to metabolic failure, that is, inability of the kidney to retain adequate bicarbonate with the respiratory alkalosis. Uncompensated metabolic alkalosis occurs when there is an increase in the bicarbonate level without a resultant alteration or increase of the partial pressure of carbon dioxide value. Thus, there will be an alkalosis due to metabolic failure, that is, inability of the kidney to excrete excess bicarbonate. Partially compensated metabolic alkalosis occurs when there is an increase in the bicarbonate level with the resultant alteration or increase of the partial pressure of carbon dioxide value, but the pH is still not within the normal range. Thus, there will be an alkalosis due to a metabolic failure, that is, inability of the kidney to excrete excess bicarbonate. Fully compensated metabolic alkalosis occurs when there is an increase in the bicarbonate level with the resultant alteration or increase of the partial pressure of carbon dioxide value, thereby balancing the pH within the normal range. Thus, there will be compensation for the alkalosis due to metabolic failure, that is, inability of the kidney to excrete excess bicarbonate with respiratory acidosis. Mixed acid-base disturbances occurs when there is either both metabolic and respiratory acidosis present or metabolic and respiratory alkalosis present at the same time of analyzing arterial blood gases. Now we will see the examples. If the ABG result shows pH 7.39, partial pressure of carbon dioxide is 51, partial pressure of oxygen is 59, and bicarbonate is 30, and SaO2 is 90 on room air. In this case, what is the result of the ABG interpretation? The pH is in the normal range, so use 7.40 as a cutoff point. So the pH is less than 7.40 shows acidosis. Partial pressure of carbon dioxide is elevated, indicating respiratory acidosis, and the bicarbonate is elevated, indicating metabolic alkalosis. The value consistent with the pH is the partial pressure of carbon dioxide. Therefore, this is primary respiratory acidosis. The acid base is inconsistent with the pH bicarbonate as it is elevated, indicating a metabolic alkalosis. So there is compensation, signifying a non-acute primary disorder because it takes days for metabolic compensation to be effective. The partial pressure of oxygen is decreased, indicating an abnormality with oxygenation. However, a history and a physical examination will help delineate the severity and urgency of required interventions. The second example, if the ABG result shows pH 7.45, partial pressure of carbon dioxide 32, partial pressure of oxygen 98, bicarbonate is 23, saturated oxygen is 92 on room air. In this case, pH is in normal range. Using 7.40 as a cutoff point, it is more than 7.40, that is alkalemia. The partial pressure of a carbon dioxide is decreased, indicating a respiratory alkalosis, and the bicarbonate is normal but on the low end of normal. The value consistent with the pH is partial pressure of a carbon dioxide. Therefore, this is primary respiratory alkalosis. The bicarbonate is in the range of normal and thus not inconsistent with the pH. So there is a lack of compensation. Partial pressure of oxygen is within the normal range, so there is no abnormality in oxygenation. We will do some problems to identify the ABG interpretation. So we will see first problem. pH is 7.28, carbon dioxide is 50, bicarbonate is 24. In this case, carbon dioxide is increased, pH is decreased. This is a respiratory problem and the pH is abnormal, that is acidic. The metabolic system, that is bicarbonate, is normal and is not at this time trying to compensate. If it was, the bicarbonate would be abnormal or alkaline. It is an attempt to increase the pH to normal range. That means in this case it is uncompensated respiratory acidosis. Second problem. pH is 7.30, carbon dioxide is 40. Bicarbonate is 18. In this case, bicarbonate is decreased and pH also is decreased. So this is a metabolic problem and the pH is abnormal. That means it is decreased. It is acidic. The respiratory system is normal, that is carbon dioxide is normal and is not at this time trying to compensate. If it was, the carbon dioxide would be abnormal or alkalotic. In an attempt to increase the pH to normal range, it should have been compensated, but in this case it is not done, so it is uncompensated. The third problem is pH is 7.42, carbon dioxide is 26, bicarbonate is 18. In this case, the carbon dioxide is decreased and pH is increased. This is a respiratory problem and the pH is normal on the alkalotic side of normal. The metabolic system is abnormal and on the acidotic side, so it is compensating. Since the blood pH level is back to normal, there is full compensation. However, if the blood pH was abnormal, it would be a partial compensation. The fourth problem, pH is 7.51. Carbon dioxide is 47, bicarbonate is 32. This is a metabolic problem and the pH is abnormal, that is alkalotic. The respiratory system is abnormal and on the acidotic side. So it is trying to compensate. However, it is only partially compensating at this time because the pH level is still abnormal. If the pH level was normal, there would be a full compensation. To call it as a full compensation, the pH should be in normal level. The last problem is pH is 7.37, carbon dioxide is 32, bicarbonate is 17. In this case, the bicarbonate is decreased and also the pH is decreased. This is a metabolic problem and the pH is normal on the acidotic side of normal. The respiratory system is abnormal and on the alkalotic side. So it is compensating. Since the blood pH level is back to normal, there is full compensation. However, if the blood pH was abnormal, it would be partial compensation. In metabolic disorder, the primary problem is with bicarbonate. The kidney is not able to excrete bicarbonate or not able to retain adequate bicarbonate. If the kidney is not able to excrete bicarbonate, it is called the alkalosis, that is metabolic alkalosis. If the kidney is not able to retain adequate bicarbonate, it is called metabolic acidosis. In respiratory disorder, the primary problem is with partial pressure of carbon dioxide. Inability to remove excess bicarbonate from the blood and the lungs is called respiratory acidosis. Excess carbon dioxide exhalation from the lungs and reduced carbon dioxide tension in the blood due to respiratory failure causes respiratory alkalosis. Now we will see the causes of respiratory acidosis. The main cause is hyperventilation due to airway obstruction. The patient is not able to breathe properly or breathing too slowly. Patients with chronic obstructive pulmonary disease, asthma, pneumonia, sleep apnea, head trauma, these patients can have respiratory acidosis. And also patients those who are in post-operative and those who are taking CNS depressant can have respiratory acidosis. Opioid overdose, benzodiazepine or diazepam, alcohol intoxication, these all can cause respiratory acidosis. Causes of respiratory alkalosis is hyperventilation. If the patient is breathing too fast, it can cause respiratory alkalosis, especially in case of a panic attack. Causes of metabolic acidosis is diarrhea, renal failure, diabetic ketoacidosis, diuretic, and ileostomy. In this condition, the inability of the kidney to retain adequate bicarbonate causes metabolic acidosis. Causes of metabolic alkalosis is vomiting, hydrochloric acid is removed from the body, NG tube suctioning, renal disease. In such a condition, the kidney is not able to excrete excess bicarbonate from our body.